sequencing ADC. There is data, it's all retrospective, no prospective data, and we're making a lot of decisions about ADC after ADC. What do we currently know about sequencing ADCs?
What we currently know is that in general, you get less benefit from the second ADC. And we're specifically talking about topo after topo. Okay, we don't have any that are non-topo ADCs, so that's something that could change. If we had novel target, novel payload, that may be a game changer, right? But so, with our TROP2 ADC and our HER2 ADC, the question is, do you feel comfortable giving them right after each other? Should you do sandwich chemo? Do you think that second ADC is not going to help? And I think that's where the debate comes in a little bit.
And so there was some data, and I guess that's why there's the northern versus southern conversation coming out of the northern group that suggests that regular chemotherapy in between ADCs is as good as an ADC, except in the population that came off ADC 1 for toxicity and not. Do you ever do that?
I do. I have to say that I tend to use clinical trials there a little bit more frequently.
Yeah.
I'm not opposed to using ADC after ADC. So, the data that we have right now is, yes, that second ADC is going to give you less benefit. Guess what? That's the same with chemo. Each line of therapy, people do exceedingly worse in terms of PFS. So we shouldn't be surprised about that. We know that both ADCs beat chemo. And so unless we really have data that chemo is better than that second ADC, I think kind of worst case scenario, honestly, they're probably about equal. And they're a little bit easier to tolerate.
TDXD in the hormone receptor positive. I think with DB06, we have a lot of people in the community who are so ready to jump to TDXD after CDK4/6 inhibitor without considering continuing the anti-estrogen approach. What do you think about that?
I think that's really dangerous. I understand the temptation.
Yeah.
Trastuzumab deruxtecan is a fantastic drug. It's giving our patients great benefit. But we really need to exhaust our endocrine therapies before we move to a drug like trastuzumab deruxtecan. So I'm not giving it after first-line CDK unless that patient did really poorly on CDK. And I'm saying they're endocrine resistant now. Less than 6 months.
Okay.
But if they didn't, then I think they deserve a shot at another endocrine therapy. In some ways, I think what's driving that is a little bit of lack of enthusiasm of our endocrine agents post-CDK and how to predict who's going to respond to a second endocrine therapy, whether that's a post-monarch CDK, whether that's a PI3 or AKT, whether that's a variety of things, an oral SERD, et cetera. We don't have a great way of predicting who's still endocrine sensitive and who isn't, right? Yeah. But, at least from the phase 1 unit, I've treated a lot of patients with oral SERDs, and some patients do really well for a long time. And so to think about that quality of life issue, I think you're essentially trying for that chance that the patient may have a year or 2 years without needing to move on to chemotherapy-like drugs.
Yeah, and maybe the reason they're progressing without getting their 2 years, which we expect, is because they've developed this resistant, a PI3 kinase, so give them the option of the combination. But now we have combination based on Avera, for example, trial, where we have combination that is not necessarily targeted approached, although you can say Afinitor is really mTOR target, or the EMBER-3, CDK4/6, and another oral SERD. I do think we have to continue down that anti-hormonal therapy approach, and there's always a tail in those patient population. So if you move on too early, you're doing those patients a disservice. I think. Totally.
I think so. I think the reasonable compromise there is on your next line of endocrine therapy to make sure that you're doing a pretty close scan to catch those quick progressors. But I don't think skipping on to ADCs without trying further endocrine therapy if your patient looks like they may be endocrine sensitive is wise.
And the toxicity, although there are some of those orals that the toxicity profile can be a little bit high, but overall they're much better than moving over to the IV options.